Of the House of Commons Standing Committee on Health. Before we begin, I'd like to ask all members and other in-person participants to consult the cards on the table for guidelines to prevent audio. If everyone stopped talking, you could. To prevent audio feedback incidents, please take note of the following preventative measures in place to protect the health and safety of all participants, including the interpreters. Use only the black approved earpiece. The former gray earpieces must no longer be used. Please keep your earpiece away from all microphones at all.
Point d'ordre, Monsieur le Président. J'entends absolument rien.
Point of order. I can't hear a thing, Chair. Perhaps it would be beneficial to call for decorum in the room. That's one. And second, through you, Chair, I would like to say to our interpreters that if we want things to work well today, for all of us, we should, as much as possible, and I do know that they do difficult work, and that they please speak a little higher or that we raise their volume, because I'm not really hearing anything at this point, even though I've turned my volume up to about 10. The technical issue wasn't as much the sound in the room as the volume. Well, last week I accepted to go ahead despite this problem, but it hasn't been solved since. Very well, we will adjourn for a moment to try to solve this technical issue that you have just pointed out to us. We suspend our work for a moment.
Order. Mr. Thériault, does it appear to be resolved for the moment? Est-ce que cela fonctionne maintenant?
Présentement,
Is this working for you? Right now, I'm at 8 out of 10 on my volume scale, but I am hearing. I'm hearing well enough. So let's just make sure if in the booth they switch interpreters, make sure that I can still hear, because this level of sound any higher might damage my hearing. But I'll work with this. I do hear well enough. And we should also adjust the sound level in the room for the witnesses who are joining us by video conference. Very well, that shall be done. Thank you. I will begin again.
Number 123 of the House of Commons Standing Committee on Health. Before we begin, I'd like to ask all members and other in-person participants to consult the cards on the table for the guidelines to prevent audio feedback incidents. Please take note of the following preventative measures in place to protect the health and safety of all participants, including the interpreters. Use only the black approved earpiece. The former gray earpieces must no longer be used. Keep your earpiece away from the microphone, all microphones at all times. When you're not using the earpiece, place it face down on the sticker placed on the table for this purpose. Thank you for your cooperation. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on April 11th, 2024, the committee is continuing its study of breast cancer screening guidelines. I would like to welcome our panel of witnesses. Colleagues, you will notice from the notice of meeting that we've arranged the witnesses in two-person panels. This was done to accommodate the schedule of the witnesses and to ensure the maximum amount of time to be able to question each one. So from 11 to 12 today, we have appearing by video conference Dr. Jean Seeley, Professor of Radiology in the Faculty of Medicine at the University of Ottawa, and with us in the room, the Canadian Cancer Society is represented by Kelly Wilson-Cull, the Director of Advocacy, and Sienna Van Duzen, Advocacy Manager, Prevention and Early Detection. We're going to begin with Dr. Seeley online for her opening statement of up to 5 minutes. Welcome to the committee, Dr. Seeley. You have the floor.
Thank you very much, Mr. Casey, and members of the committee. Thank you for the opportunity to comment on the draft Canadian Task Force Breast Cancer Screening Guidelines. As a breast imaging specialist, I diagnose women along their entire cancer journey. I detect breast cancers through screening, or I diagnose them after a woman presents with a symptom of a palpable lump. I perform biopsies and I localize breast cancers for the surgeons. I interpret the imaging of women diagnosed with late-stage or recurrent breast cancer. I speak to women at all stages of breast cancer, and a screen-detected cancer found before symptoms occur is a very different diagnosis than one found because of symptoms at stage 2, 3, or when it's incurable at stage 4. The task force falsely equates an additional imaging test as a harm comparable to delayed diagnosis of late-stage breast cancer. My patients attest that the severity of the harm of a delayed diagnosis vastly exceeds any stress associated with any additional imaging test. Equating these harms is a false equivalency. The recent draft guidelines released by the Task Force for Breast Cancer Screening have sparked significant concern within the medical community. And as an expert included on the evidence review panel, I find their recommendations profoundly disappointing. These guidelines ignore robust recent evidence supporting the initiation of screening at age 40, a standard now adopted in the United States and numerous other countries. The task force recommendations are anchored in studies dating back 40 to 60 years, utilizing obsolete technologies like film screen mammography. As experts, we recommended against including these outdated data, which overtook monumental advances in breast cancer treatment, including hormone receptor positive treatments like tamoxifen, less invasive surgical options like lumpectomy and sentinel lymph node biopsy, and modern immunological and chemotherapeutic agents that have revolutionized breast cancer management. The task force working group interfered with our expert recommendations and insisted on using these studies. The task force approach diminished the importance of recent observational studies that involve millions of women comparing screening to no screening with updated diagnosis and treatment. These studies include one Canadian study of over 2.7 million women screened over 20 years, which demonstrated a 44% reduction in breast cancer mortality in women who began screening in their 40s. And similar studies in Sweden show even greater benefits with reductions in mortality of 50 to 60% in women aged 40 years and older. Further, the task force used the old trials to evaluate cancer stage at detection and therefore missed the benefits of early stage detection with up-to-date screening technology. The improvements in screening technology in the past 15 years have improved breast cancer detection by 20 to 40%. Breast cancer is a devastating diagnosis, but the harms are mostly preventable when it is detected early. The survival rates are starkly different across stages. Nearly 100% 5-year survival for stage 1, detected through screening, compared to only 22% 5-year survival at stage 4 when the disease has become incurable. Further, the treatment is much less intensive and costly when treated early, where stage 1 cancer cost an average of 30,000 Canadian dollars to treat, compared to up to $500,000 for stage 4. And systematic screening programs in Canada find that 87% of breast cancers are stage 1 at diagnosis. The task force disregarded data that showed that women of race and ethnicity other than white are more likely to be diagnosed with breast cancer in their 40s. A one-size-fits-all approach to recommending screening only starting at 50 discriminates against these women and contributes to their twice higher rates of advanced breast cancer due to stage delays in screening and access to screening and delays in diagnosis. The task force acknowledged that women with dense breasts were twice as likely to develop breast cancer as women with non-dense breasts. However, it failed to recognize the reduced sensitivity of mammography in these women, which drops from 90% in women with non-dense breasts to 60% in those with the densest breast. The task force ignored high-quality randomized study that showed that adding screening with MRI reduced interval cancers, those cancers diagnosed by symptoms after a normal mammogram, by 80% and by 50% in women screened with supplemental breast ultrasound. And these have been shown to be evidence-based acceptable surrogates for breast cancer mortality, but the task force did not consider them despite expert recommendation. So we must demand that our health policies be reflective of the latest scientific evidence and best practices in medicine. Thank you very much for your attention.
Thank you, Dr. Seeley. Next, the Canadian Cancer Society, Ms. Wilson Cull or Ms. Van Dusen, or a combination of the two. You have 5 minutes. Welcome to the committee. You have the floor.
Thank you. Good morning. My name is Kelly Wilson Cull, and I'm the Director of Advocacy. With me today is Sienna Van Dusen, who's the Advocacy Manager of Prevention and Early Detection. The Canadian Cancer Society is the voice for people who care about cancer in Canada. As a part of our commitment to improving and saving lives, we are pleased to provide recommendations on breast cancer screening. Cancer is the leading cause of death in Canada, and it is predicted that 2 out of 5 people will be diagnosed with cancer in their lifetime, and approximately 1 in 4 will die of the disease. In Canada, an estimated 1 in 8 women is expected to be diagnosed with breast cancer during their lifetime. Breast cancer is the most common cancer among women in Canada, and despite fewer women being diagnosed with breast cancer under the age of 50, it remains the leading cause of cancer death for people in Canada aged 30 to 49. While data from a new study shows that breast cancer incidence rates for women in Canada in their 40s have increased over the last 55 years, overall breast cancer incidence and death rates in Canada are trending downwards as early detection, treatment, and care continues to improve. Yet, we must acknowledge that international data indicates that more Black, Asian, and Hispanic women with breast cancer are diagnosed before the age of 50 years old and are more often diagnosed with a later stage disease compared with other women. This means that waiting to start screening at age 50 could result in missed opportunities for early detection among women in these communities. Evidence from trials, modeling studies, and real-world data have shown benefits from regular breast cancer screening starting at age 40. Timely access to breast cancer screening is critical to finding breast cancer early when treatment is most likely to be successful. We continue to hear from people living with breast cancer that they do not feel represented by the current guidelines because they do not reflect their lived experiences. Further, according to a national survey, most respondents support expanding systematic access to breast cancer screening to include women aged 40 to 49. CCS supports expanding access to breast cancer screening for women, trans, non-binary, and gender-diverse people aged 40 to 49 at average risk of developing breast cancer. We also need to ensure that there is clear guidance for people who have an elevated or high risk of developing breast cancer, such as people with certain genetic mutations, family history, or dense breasts. I will turn my remarks over to Sienna.
Merci, Kelly. Actuellement, un nombre...
Thank you, Kelly. Currently, a growing number of provinces in Canada have begun to offer or have announced that they will expand access to breast cancer screening services from the age of 40. So, while the provinces and territories review new national guidelines, the CCS is asking the remaining jurisdictions to include women aged 40 to 49 at average risk of breast cancer in their organized breast cancer screening programs. This change would reflect new evidence that was published between the last update of the Canadian guidelines in 2018 and those presented a few weeks ago. Data on participation in breast cancer screening programs in Canada will soon be updated by the Canadian Partnership Against Cancer. Until then, our data date from before the pandemic, and breast cancer screening programs are not meeting the national target of 70% participation. It is therefore important to increase capacity to meet the needs of people in Canada while taking into account, more specifically, the needs of underserved populations, people from racialized or Aboriginal communities, as well as those with low incomes or living in rural or remote areas, and adapting our services accordingly. In addition, we recommend that the federal government invest more in research to deepen our knowledge about cancer screening and risks of the various ways it is approached. It's also important to fill data gaps so that we have a better understanding of the impact of breast cancer in Canada. The PAN can improve data across the country. Moreover, governments need to invest in prevention, early detection, and treatment to reduce the impact of labor shortages, among other aims. This includes new investments in human resources, the integration of new technologies, digital infrastructures, and the modernization of care pathways, which, if implemented, would meet the current and future needs of Canadians. Finally, I'd like to thank you for taking the time to listen to our recommendations. We look forward to continuing to work together to better support those affected by cancer, because it takes a society, a whole society, to take action against cancer. Thank you so much. Thank you. We will now move into our round of questions, beginning with the Conservatives. Dr. Ellis.
Thank you very much, Chair, and thank you to our witnesses for being here in this very, very important topic. You know, I think that what we've heard very clearly, of course, is that in spite of what the task force has said, the science really is perhaps changing very rapidly. It's a dynamic environment that some science is not being taken into account, which is very, very discouraging. And to you, Dr. Seely, I know you don't have a crystal ball, or if you do, I'd be happy to borrow it now and again. But that being said, you know, the task force has put out their draft guidelines. Do you think there's a way, with the voice of this particular committee, of course, adding your voices to it, that the draft guidelines from the committee can actually be changed to be more reflective of this current science?
Thank you very much, Minister Ellis. The problem with the task force recommendations is that they dictated what evidence could be used, and they insisted on including the randomized control trials that were 40 to 60 years old. Because of that, the evidence that was generated for these recommendations does not reflect the most up-to-date evidence. And my concern is that these draft recommendations will not change despite the feedback. And so our recommendations are to not adhere to any of these recommendations and to actually start again with the evidence that experts recommend be used.
Well, thank you very much, Dr. Seely. And going down that line, you know, one of the concerns that I think we should all share, certainly one of my concerns would be that what we don't want is women in Canada getting mixed messages, because I think that creates a difficulty. So if we believe, and I believe what you're saying is true, that the draft guidelines will become the guidelines, how can we amplify the voice that says on behalf of women that you should be able to access screening for breast cancer at age 40? I live in Nova Scotia. That is a reality there, that women can access screening, as you well know, at age 40. Then would it behoove this committee to write to every provincial minister of health with the final report of this committee to ensure that they hear that message loud and clear? Is that the path, another path that we could possibly go down to ensure that the message is heard clearly?
Thank you very much. I think that would be certainly would help. But what we know is that all the provincial and territories that have now updated their screening guidelines, the only two that remain are Quebec, which is looking at the evidence, and Manitoba. The problem is that these task force guidelines are adhered to by many family physicians in the country. And we know in British Columbia, when the task force changed their recommendations in 2011, British Columbia, which like Nova Scotia allowed women to be screened in their 40s, saw a marked decrease in their participation in women in their 40s, dropping from 50% participation to 25%. So I believe that we must do an even better message to not adopt these guidelines, as they are adhered to by many family physicians who don't have time to follow the most up-to-date evidence.
Well, thanks for that, Dr. Seely, and through you, Chair. Do you think there's an opportunity then to target the College of Family Physicians of Canada so that family physicians can hear this message very clearly? Obviously, the science exists, but the most part of this is a communications exercise to, as you mentioned very clearly, family physicians and to women in Canada. And I realize that you're not a marketing expert, but what I'm asking is how to get that message out there so it's loud and clear without, sadly, the task force changing their guidelines.
I think for sure a message from the government and from this committee would be very helpful. It would probably be very useful to target it to the family physicians who have a more limited knowledge about this, and to amplify this at the level of the screening programs. I would encourage Quebec and Manitoba to be able to have a systematic approach. The programs that have been delivering screening are excellent, and we would recommend that all of that screening be done within a screening program and by self-referral starting for age 40 and older.
Thank you very much. And to you, Ms. Cull, is that approach kind of something that the Canadian Cancer Society...
Est-ce que cette approche pourrait être, et le message pourrait être amplifié par la Société canadienne du cancer? Merci pour le travail que vous faites. Oui, la Société travaille activement avec tous les niveaux du gouvernement du Canada sur cet enjeu. On reconnaît que beaucoup de programmes...
Can you just... I'm showing English, but I'm getting French interpretation right now.
Sorry about that.
Just, we're going to get you to repeat your answer once we check into what the technical problem is. Okay. Okay. So, all right. I'm just trying to come up with something to say in order to be able to properly test. Okay, you're now getting it in French. Okay. Okay. I believe the problem is resolved. When this happened, Mr. Ellis still had about a minute left on the clock, but you were in the middle of your answer. So please go ahead and complete your answer.
Thank you very much. I think you used the term mixed messages, and that's part of the challenge that we're really experiencing as a result of these guidelines. We have provinces and territories across Canada with different approaches to breast cancer screening, and what that has inadvertently created is inequity in terms of where you live dictates what your breast cancer screening access looks like. From the Canadian Cancer Society's point of view, we are urging all provincial governments to reduce access to systematic screening starting at age 40. But we recognize that we have some provinces, I'm from Nova Scotia as well, who have access to self-referral, for example, and have for some time, whereas provinces like Ontario have committed to rolling this out, but aren't quite there yet. And so where you live really shouldn't dictate your access to breast cancer screening in Canada, and we want to ensure that there's an equitable approach. And at this point, we know that provinces are taking their cues from the task force. And so we need that leadership and we need that strong infrastructure to ensure that the provinces are getting the most accurate, up-to-date, comprehensive guidelines so that they can make the right decisions for their constituents.
Thank you. Next, Mr. Nakvi, please, for 6 minutes.
Thank you very much, Chair. And I'll be sharing my time with Dr. Pawlowski, if that's okay with you. I wanted to thank all the witnesses for being here, and particularly Dr. Seeley, who I had the opportunity to meet, I believe, a little over a year ago on precisely this issue. And I'm thankful to her for the guidance that she gave me on the task force work. And I must say that since that time, the issue around breast cancer and screening has become personal to me, as my mother was diagnosed with breast cancer. Although she's an older woman, it was the screening that caught her cancer on very early stages, and she's on an incredible journey of recovery and living her full life. So I must say that I feel very frustrated by the draft guidelines that the task force have issued, and thankful that this committee is doing the important work and listening from witnesses. Dr. Seeley, I know when we had met, you spoke about a study that you had done, I believe in 2023, that looked at how screening women aged 40 to 49 impacted net survival. Would you be able to elaborate for us on some of the key findings on why you believe screening age should be lowered to 40?
Thank you very much, Mr. Naqvi. I'm sorry your mother was diagnosed, but I'm very grateful that she was screen detected, because it's a very different diagnosis. And what we did is, because, as was noted, there is a geographic difference in screening programs in the country. Some women who live in provinces of British Columbia, Nova Scotia, are able to participate in screening programs, and others have not been. We were able to look at over 55,000 women diagnosed with breast cancer in Canada over a 10-year period. And what we could see is that the women who just lived in a province where there was a screening program offered for women in their 40s had a significant increase in 10-year net survival of their breast cancer, which was on par with some of the chemotherapeutic agents we use for every woman diagnosed with a hormone receptor positive cancer. And we found that there was a significant decrease in the breast cancer mortality for those women living in the provinces that had screening programs. What we didn't know is how many women in those provinces were actually screen detected, because that's not something we actually currently track. But we could see this marked improvement, and it correlated with a study we had done previously that showed that the stage at which a breast cancer was diagnosed was significantly lower, stage 1, if they lived in those provinces compared to the ones that did not screen. And it also had a benefit on women who were older, in their 50s. It also increased the improvement in their stage and overall survival.
Thank you. Just very quickly before I pass it on to Mr. Pawlowski, one of the caution we hear is about false positives, that if you lower the age, that it may increase that particular incidence. Can you comment on that? Is that a misguided fear in this instance?
So the task force has called these false positives, which is really not a correct term. We're not telling a woman when she's recalled from screening that she has a cancer. We're simply telling her she needs some more imaging to identify if there's an abnormality. And over 94.5% of those turn out to be just overlapping tissue. We're looking at a three-dimensional structure and showing it in 2D, and it's something that we can reassure the woman at that time. We do need to do biopsies, and about 1% or less are benign. But again, this is a very well-tolerated procedure. I do biopsies all the time, and women tell me they would much rather have this kind of abnormal imaging test than have a delayed diagnosis of breast cancer. The women who have that delayed late-stage diagnosis are angry that they had lost the opportunity to be screen detected.
I'd like to ask you, Dr. Seeley, about the fact that it seems like the task force ignored the advice of their own experts, which is, to me, very troubling. Could you start off by just clarifying for us, like, who is on the task force to begin with? What is their level of expertise?
So the working group of the task force is carefully selected to have no expertise in cancer imaging, diagnosis, or treatment. So I was invited to be an expert on the evidence review, which is the group that looks at the evidence and provides this to the working group to be able to inform their recommendation.
Now, can I interrupt you? Are you just supposed to compile the evidence, or are you supposed to also be evaluating the evidence?
Well, for my job as expert advisor to the evidence review, we would recommend the evidence. We put it into context. These are people who don't understand imaging, and we gave a lot of recommendations, including the fact that the technology in those old trials was no longer used. But the working group overrode our recommendations and insisted to the evidence review panel that they must include those studies.
So who is on the evidence review panel?
The evidence review panel, there are three different groups across the country. The one in Ottawa was consisted of methodologists, epidemiologists, whose methodology expertise is to analyze the evidence. And that's who we were helping to advise. The working group is separate, and we never directly interacted with them, but we could see their comments and their responses to the evidence review that dictated the evidence that could be used.
Thank you, Dr. Seeley. Thank you, Dr. Pawlowski. Suite M. Thériault pour 6 minutes, s'il vous plaît.
And now we will move to Mr. Thériault for 6 minutes, please. Thank you, Chair. I would like to thank our witnesses for their testimony. Very helpful. Let me begin with Dr. Seeley. For women of 40 to 49 years of age, the recommendation of the task force is not to go to systematic routine screening by ultrasound, and they seem to underscore the rational decision made by a patient when well-informed, which I imagine would have to involve a discussion between the patient and their doctor, who would have to be well-informed on the benefits and drawbacks of screening. In a study published in 2022, we see, and I quote, free translation, the obstacles for in this of individual decisions involves how much you know about the situation. And doctors had difficulty actually listing risk factors of breast cancer other than family history, such as ethnicity or breast density. Some doctors lacked competency and could not even give a general risk percentage for breast cancer. Don't you think that the lack of knowledge on doctors' part of the risk factors and even of the various technologies used to detect breast cancer could bias patients' approach?
There's two factors to that answer. One is that 80% of women in their 40s who get breast cancer have no risk factors. And this is why we don't recommend risk-based approach to screening. We recommend systematic screening starting at age 40. We would miss too many cancers otherwise. There is a second point, and that is that there is a tremendous lack of family physicians. We know in Ontario we have over 2 million people who do not have a family physician. So this poses a very big obstacle to getting access to screening and to have that kind of a discussion to allow them in. And thirdly, you mentioned a very good point. There is a lack of awareness of risk factors, and we see even women who should be in high-risk screening are not advocated to have earlier screening than age 40 when they should be in a high-risk screening program. So these are obstacles that the task force are placing with these recommendations that are really going to accentuate the confusion and the disparities that we see, particularly among some of the racial and ethnicities that I mentioned. So it's a very important point.
Je vais poser une question qui n'a pas été encore.
Let me put a question that hasn't been put yet in our meetings. Given that the specialists and experts who come to see us, including the Canadian Cancer Society, have told us that we do need systematic screening for people between the ages of 40 and 49 years. Why is it that the task force decided to sort of not pay attention to this information? Is there an economic factor that hasn't been stated explicitly for their approach, the CTF's approach? Of course, a good deal of money can be saved using their approach. Why are they remaining in their with their position?
That there is a very strong anti-screening bias in the working group members. Before the task force even began their work on this guideline, the co-chair publicly stated that she didn't believe there was any new evidence, and she didn't think that the recommendations would change. Many of the other working group members are very strongly anti-screening, and they've already publicly published or commented on this. It's I think a lack of knowledge or really informed patient care, and I'm not sure if there are any other factors, but I think it's a good question.
Mais est-ce combien de temps, Monsieur le Président?
How much time, Chair, do I have left? You have a minute and a half, sir. Thank you. Then I do have time for another question. Well, look, I find this striking. Do you feel that the prejudices that you're mentioning with regard to the task force are so deeply embedded and prejudicial to women between 40 and 49 years of age? I mean, what sort of prejudice is this? Because this seems to come up rather often.
I'm so sorry, I didn't really understand the question. If you're asking
Qu'est-ce qui est
about
si
the prejudice?
préjudiciable?
All right, so what is the prejudice at issue? I mean, we hear that there seems to be some prejudices against screening. So what type of prejudice is this, compared to saving lives? They didn't have this prejudice.
The biases that we see are that the belief that treatment will resolve all breast cancers and is not dependent on stage. We've heard anecdotes that a patient might benefit from at a stage 3 from breast cancer treatment and do better than a stage 1. We have the data that shows that is absolutely not the case. And this comes from a belief, I think, based on a lack of awareness of all the data and a strong belief that treatment is going to solve anything. I can tell you that I see too many women actually dying within a year of their diagnosis of breast cancer, and that is exactly not our experience. So I think it's a belief that incorrectly that chemotherapy will resolve and solve all the problems.
Merci, Mr. Thériault. Dr. Seeley.
Thank you, Mr. Thériault.
Ms. Zarillo, please, for 6 minutes.
Thank you, Chair, and thank you, Dr. Seeley, for all your testimony today. And definitely, we've seen a reaction from the community. We've seen a reaction from women, that have a hard time being believed on many things, but certainly on their health. So I do hear your comments about going back to the drawing board. It seems like this study is perhaps antiquated and needs to be modernized. Dr. Seeley, I'm going to ask you about what special considerations you would want if they go back to the drawing board on this task force. But before I do, I wanted to share my personal story. I was interesting. I was diagnosed with breast cancer in my 40s, and I think people forget that you have children. Most women that are diagnosed with breast cancer in their 40s have children. So my youngest was in grade 6 at the time. And I think some of the visceral response we've seen from community is the fact that this task force didn't seem to consider what impact it has on the people that experience this. So for me, it took me 2 years to get my doctor to get me screened. And you mentioned about the supplementary screening. I have dense breasts. So in the end, it was close to my pectoral muscle and needed an ultrasound to be found. It was lobular, not ductal. So it grows in sheets and it cannot be felt in a lump. And the other thing was that I chose to have a double mastectomy because the stress of not being believed for 2 years and then being at stage 2 before they found it and having to tell my children was very, very difficult. And can I say that Terry Fox is from the Tri-Cities where I am, in Port Coquitlam. Their runs in Coquitlam. And every year, the students of ST43, our school district, do a Terry Fox run. And to see your 6-year-old put your name on their I'm running for is something that I wouldn't want any woman to have to see. So I'm sorry I'm upset today. I didn't think I would get upset, but I wonder if you could let us know, what are the new technologies? What is the task force missing, and what are the special considerations that they need to do when the government sends this back for reconsideration?
Thank you so much, and Ms. Rilla, and I'm so sorry about your experience. I have to say that I hear this and see this almost every week, and you are not alone. There are many, many women, and this is why we're here today to do a better job for women in their 40s when they are in the prime of their lives, productive members of society and parents. And breast cancer doesn't just affect a woman. It affects the whole family. It affects grandparents, spouses, and children. And this is why we are really working to change these guidelines. These guidelines cause tremendous confusion. And unfortunately, we estimate that even using the estimated numbers of 1 per 1,000 lives lost or saved by screening, but lost if you don't screen women in your 40s in Canada, this translates to 400 to 600 women lives lost per year. So this is a huge impact on our Canadian society. The technology has improved dramatically. I mentioned 40 to 60% or 20 to 40%. This is based on, we now use digital mammography, which is particularly better in women with dense breast tissue. We also need digital breast tomosynthesis, which is another technology that has been shown to increase cancer detection rates by up to 40% and is being used in many centers, multiple centers in the United States, and is slowly being used in Canada. Do I have another minute? So just to say that reducing the cancer and diagnosing it at stage 1 is possible. We know with now randomized trials that we can screen women with dense breast with MRI and reduce their interval cancers by 80%, and they are diagnosed at stage 1. So this is all the technology that we can use to inform up-to-date evidence.
And I just wanted to say, in my experience, what worries me the most is non-white women, women of color, women that are more likely in their 40s, 50s, knowing how hard I had to fight. I'm wondering how we are disadvantaging non-white women with this antiquated task force study.
Do I have the floor? I
Yes.
would like to. Oh, thank you. The women who I see more likely to present with advanced breast cancer are women of all race and ethnicities other than white, and this is because the peak age of which they are diagnosed with breast cancer is in their 40s, and they are not able to access screening programs in many parts of the country based on these guidelines and based on a lack of access to even a family physician. This is unfortunately, similar to what we see in some of the developing world with advanced breast cancers presenting in these women at 2.5 times higher rate than white women in Canada. So these guidelines are very harmful, and that is why I would recommend that we reject them and start again.
Thank you, Ms. Cirillo. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and I just want to thank MP Cirillo for sharing, and that touched me. There aren't a lot of topics that get me really teary. I'm generally a very strong person that can hide a lot of emotion. This is the subject where I don't hide a lot of emotion. My mom would have been one of the 400 to 600 women that would still be alive today had more screening been available. My mom passed away at 49 years old. She was diagnosed with breast cancer when she was 48 years old. She left behind 4 little kids. I was the oldest. I had to take on a lot of extra responsibility through her chemo, through her radiation, through her palliative stage, and then eventually after her passing. This isn't something I would wish on anybody. This isn't something that I hope another person ever has to struggle with. And I am angry. I'm angry with the task force's guidelines. I think that they fail to recognize the value of lives of women and their families and the fear that they have created by saying that additional screening is somehow not valid. So I just want to open it up to you, Dr. Seeley. I really have appreciated your piece, and I was wondering if there is a piece that, and you talked about the fact that you're seeing more women that are passing away within 1 year of having diagnosis. What do you think, beyond what the guidelines have put forward, we could do to make things better for the outcomes of women?
Thank you so much, and I'm so sorry for your loss. I think probably every one of us has a member of our family, but it's even more potent when it's your mother. The recommendations that we have are that women should start to have a risk assessment for breast cancer with informed, up-to-date tools to recommend what their next steps should be, starting between the ages of 25 and 30. And this is in alignment with the European guidelines and the American guidelines that suggest we should be thinking about breast cancer as early as 25 to 30. We should be recommending systematic screening starting at age 40, and we should be allowing self-referral to a screening program. We have extremely good quality screening programs in Canada. This is what we would recommend. It is a woman's decision whether she wants to be screened or not, and we know that the participation rates are about 60%. They could be better, but we know that women in their 40s are begging to be allowed to be screened and to be allowed into the screening programs and to benefit from early detection because they want to live a healthy life, to be there for their children for many, many years. So those are the major recommendations for the young women. For women who are 74 years and older, the life expectancy for women has changed and improved dramatically, and we would recommend continuing to screen women in their older than 74 as long as they have a life expectancy of 7 to 10 years, which is the majority of women in their 70s. These are the recommendations that align with international standards, and these are the ones that we would recommend for Canadian guidelines.
Thank you. I really appreciate that. I know I've had a number of women that are in their 70s bring up the concerns they had about screening stopping at 74 for exactly the points you raised. And so I do think that that's an important piece to make sure we have involved. I'm going to open this up to the Canadian Breast Cancer, or to the Canadian Cancer Society, sorry. You guys, what recommendation would you put forward very succinctly to... Do you think that we should have reversal of the guidelines that were just put forward from the task force?
It's a difficult question, but we have heard it all today. Like, we need to have access for women in their 40s to 49. And so, whether it's working with them in the capacity that they are today to get there is the public consultation that we are encouraging our community to be very much a part of in hopes that might make a bit of a difference. We've also requested that a report be publicized after to understand what has been heard from the public. But I guess a concern is that we have been consulted in the past, and our thoughts and considerations in the research that has been provided hasn't always come through. And so hoping that this would be different, but also cautious. So we'll see.
Thank you, Ms. Van Dusen. Oh, yes, please, very briefly.
Just to add there also that we had requested that the task force also consider high risk and elevated risk guidelines in this current review, and that's something that we would also be looking to see. It's important to know that these screening programs are really for average risk populations, and we need separate guidance for those at elevated and high risk.
Thank you. Ms. Sidhu, please, for 5 minutes.
Thank you, Chair. Thank you, all the witnesses being with us. My question goes to Dr. Seeley. Dr. Seeley, I would like to start where we left off in the last meeting. We briefly spoken about outreach to women across provinces. We heard shocking testimony that in some cases women are left to their own resources. Sometimes they hear about the need to get screened from women's magazines and not from the physicians. What recommendation can you give to this committee about raising awareness among women about screening?
Thank you very much, Minister Sidhu. You are exactly, this is exactly the experience. We see a lot of barriers, and for the reasons I mentioned earlier, the College of Family Physicians, who see a lot of women in the more rural or remote communities, very much adhere to the Canadian Task Force guidelines. They have extremely busy practices. They're seeing all aspect of medical problems, and they don't have the time to get informed, so they rely very heavily on the Canadian Task Force guidelines. And this is a recurrent theme. We have thousands of people across the country who tell us that their family physician refused them to be screened in their 40s. Even though the task force does acknowledge it should be an informed decision, they are just simply following the final guideline to not recommend routine screening in these women. So this is the biggest reason why these guidelines are really so harmful, because they will pose a barrier. Once the guidelines are to recommend that a woman can self-refer in the 40 to 49, there are outreach programs that are occurring across the country in different screening programs. We have some programs that have mobile vans or coaches that go to different underserved communities. We have screening programs in the Northwest Territories and in Yukon. We're trying to establish this now in Nunavut. So it is feasible, but the message of not recommending routine screening is one that is the most harmful. So I think that is really where we have to focus to start.
Thank you. My next question is about American guidelines published on April 30th. And could you talk about the committee, about the methodology and their justification for reducing the recommendation age of screening at 40? I know you said it saves almost 2,600 lives, which is a lot of life. And then we heard the testimony. And Dr. Seeley, you mentioned a study done in Sweden on breast cancer imaging. Could you expand on their results and overall on the current European guidelines too?
So let me start with the American recommendations. So the U.S. Preventive Task Force recommendations that were released earlier this year, they started their methodology with the principle that they knew that screening mammography was effective at reducing the breast cancer mortality. And so they did not reevaluate the old randomized control trials, recognizing that it had been proven already to be effective. And so they only looked at data from 2016 onward, and they included some of the up-to-date evidence showing the benefit of early-stage diagnosis with screening and the increased incidence of breast cancer in women in their 40s. And that was the basis. They also looked at the evidence of the disparities amongst races and ethnicities that showed that they were not able to access screening. And that was one of the big reasons to change the guidelines to include women in their 40s. We know in your question about Sweden, about that more recent observational trial, showed that for women that had been screened and they were able to compare no screening, and then they initiated screening and they compared the mortality from breast cancer Once they had initiated screening, they compared the women who did not participate in screening with the women who did participate. And what they found was a 60% reduction in breast cancer mortality comparing women who did not choose to participate in screening with those that did participate in screening. So huge benefit in mortality, in lowering the mortality. And this accommodated all the recent advances of treatment. And so it showed that even for the same treatment of breast cancer, screen detected was associated with a very marked improvement in breast cancer mortality.
Thank you, Dr. Seeley et Ms. Sidou. Ensuite, M. Thériault pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Thank you.
In an article published in the Devoir on the 30th of May 2024, the chair of the Canadian Task Force explains the difference between the results of recommendations from the task force in Canada and the American version. For example, that the Canadian Task Force looked at 42 studies about the values and preferences of patients. And she explains, this is Dr. Thériault here, and I quote her, that women in the 40s, based on these studies, when they're presented with a scenario looking like what we have the figures for, the number of illnesses and deaths and how many more ultrasounds they had to have, most of them didn't want to go through screening. I thought that a little surprising that we're using studies about, supposedly some women's preferences about ultrasound or MRI when we're talking about people's lives.
Our cancer community is quite strongly advocating for access, and I think it's also important to remember that the opportunity to screen is a choice, and that women can decide not to be screened if that is not their preference and it does not align with their values and preferences, and especially knowing the risks and benefits. So I think that it is fair to consider that in this very holistic approach. We're looking at mortality, we're looking at costs, we're looking at quality of life, I think is also an important factor. So there's a lot to look at here, but in our developing our own recommendations, we also took a quite holistic approach.
Merci. Dr. Seeley.
Thank you. Dr. Seeley, according to the task force that's made its recommendations, the risk of excessive screening are much higher than its potential advantages. Useless tests, excessive diagnoses, overdiagnosing, and even biopsies. So do you think that this makes sense given the studies overall?
A couple of great questions. I think the exaggerations of the abnormal recalls, what they've called false positives, is vastly exceeded. And our patients tell us it is not, they are so grateful when they get this, and they are happy to return to screening. The majority of studies show this. The overdiagnosis, the case of diagnosing a cancer that is not going to lead to death in a woman because she might die of another cause, is a small acknowledged risk of screening, but it is much less likely in a woman in her 40s who has another 40 to 50 years ahead of her than a woman, say, in her 80s who might die of other causes. So the exaggeration of this as a harm to prevent a woman from benefiting from early diagnosis is something that I think is exaggerated.
Thank you, Dr. Seeley. And the last person to pose questions to this panel is Ms. Zarillo, please. 2.5 minutes.
Thank you. Dr. Seeley, I'm concerned about the reality of discrimination in medicine, and I wonder if a modernized, back to the drawing board approach to this task force would offset some of that discrimination.
There are international guidelines that include experts as well as methodology expertise to produce guidelines. I know we're speaking about breast cancer here, but we have colleagues who are outraged by the task force recommendations for prostate screening, lung cancer screening, cervical screening, and a whole host of others. The expertise is there. You must include people who understand the disease and who are aware of the up-to-date evidence to be able to produce guidelines that are going to save lives and make a difference. So we need to go back to the drawing board.
Thank you. And I'm going to finish with asking Ms. Cull about the elevated high risk. So could inclusion of recognition of elevated and high risk parameters have impact on breast cancer survival or breast cancer diagnoses people, and what impact would it have?
Certainly, as I said, we really see an importance around distinguishing between what population-based screening programs are there to do, and then a differentiated pathway for people who have elevated and high risk. We hear from patients, we've done a lot of work really surveying patient groups, that people are showing up at their family doctors with signs and symptoms, and even being refused screening access within that age group. If you have, for example, a family history, your risk pathway needs to look different than someone who is asymptomatic or not presenting signs and symptoms. So we see, again, just back to the mixed messaging point, we see different provinces and territories with different approaches to high-risk guidelines, and again, that creates this inequity of access province to province. We need leadership in this country to ensure that all Canadians, whether you are average risk, high risk, elevated risk, are getting a consistent approach to screening, regardless of where you live in Canada.
Thank you very much. That concludes the time that we have available for this panel. I want to thank you so much for being with us. I don't think there can be any greater statement on the importance of your work than the level of emotion and personal attachment to these issues that you've seen demonstrated, the parliamentarians posing questions today. So thank you for what you do, and thank you for being with us. We're going to suspend for about 3 minutes to allow our witnesses to take their leave and to get the others set up and tested. So the meeting stands suspended. Thanks to everyone. and I would like to welcome our witnesses for the second hour of today's meeting and thank them for being with us. We have appearing as an individual Dr. Martin J. Yaffe, Senior Scientist at Sunnybrook Research Institute, University of Toronto, and also appearing by video conference on behalf of the Canadian Society of Breast Imaging, Dr. Supriya Kulkarni, President. Welcome to each of you for being with us. We're going to start with Dr. Yaffe for opening statements of up to 5 minutes. Dr. Yaffe, you have the floor.
Thank you very much, Mr. Chairman, and I'd like to thank the committee for this opportunity to discuss this very important issue. The decision to participate or not in breast cancer screening should be up to individuals. But to inform that decision, they need accurate, unbiased, and accessible information regarding benefits, limitations, and potential harms associated with screening. The Canadian Task Force on Preventive Health Care provides advice to primary care physicians and the public, but disturbingly, the information they've provided has been distorted to discourage participation in breast cancer screening, and this may be responsible in part for the low participation rates mentioned earlier by Ms. Van Dusen. Just who I am, I'm a senior breast cancer research scientist who leads a group of 20 researchers at Sunnybrook Research Institute in Toronto, and I also co-lead the imaging research program at the Ontario Institute for Cancer Research. Much of my work over the past 44 years has focused on breast cancer screening, and my group has helped develop and validate the technique of digital mammography, which is now used worldwide. As well, we've established breast density as a risk factor for breast cancer. In 2015, I helped write the IARC World Health Organization Handbook on Breast Cancer Screening, and I've been at odds scientifically with the task force since 2011. Dr. Seeley already mentioned the randomized trials conducted in the 1960s, proving, to 1990s, proving that earlier detection of breast cancer by mammography screening can help reduce breast cancer deaths. And with the modern developments in both screening and breast cancer therapy, more recent large studies, including the one done in Canada mentioned earlier, showing a 44% reduction in breast cancer deaths in women from the age of 40 onward participating in mammography screening, really has shown definitively that breast cancer screening of younger women saves lives. And certainly this is a much larger benefit than seen in those earlier randomized trials conducted 40 to 60 years ago. In addition, screening detection of breast cancers of younger women can, in some cases, give them back 20 years of additional life with their families, in the workplace, and interacting with society. A decision on screening involves weighting the benefits of averting premature death against the limitations and possible harms. The task force has not done this. Instead, it's made blanket statements about harms, suggesting without evidence that they may approach or outweigh the level of benefit for younger women. The task force did commission a project to model screening outcomes. A table in their guidelines suggested very low benefits from screening younger women. However, we have not had the opportunity to see the details of how they did that work. I've published modeling results in 2015 and 2022, some using the same model as the Canadian Task Force, and the U.S. Preventive Services Task Force also commissioned modeling to inform its 2024 guidelines update. Results coming from 5 NCI-funded models in the U.S. agree well with those from my lab, and they show continuously increasing absolute and relative benefits of breast cancer mortality reduction as the starting age for screening is reduced to 40, the stopping age is increased to 79, in other words, above the 74 we've been discussing earlier, and screening is performed annually rather than every 2 years. The worst results are obtained when screening is done at 3 years, a strategy suggested by the Canadian Task Force with no evidence at all to support it. Modeling allows us to actually weigh the benefits versus the possible harms of breast cancer screening, and it showed that the net improvement in terms of quality adjusted years of life, and I could talk about that later if you want, gained by screening increases when screening starts earlier, ends later, and is annual. and the benefits consistently dwarf the harms. As an invited expert to the Ottawa Evidence Review and Synthesis Center, I had the same experience as Dr. Seeley of interference by the task force. Against the advice of invited experts, they focused on the older, now obsolete randomized control trial data, and they set arbitrary thresholds to assess the data and used too short an observation time to allow the full impact of the benefit to be measured. The task force takes a less is more position towards screening, and this comes at the cost of thousands of lost lives, accompanied by increased morbidity due to later treatment of disease. Of course, the task force also insists on specifying outcomes only in absolute quantities, and that minimizes the perceived level of benefit, especially for lay people. 2 lives saved per 1,000 seems like a small benefit, even if it represents 40% mortality reduction and 470 or more deaths avoided each year in Canada. It's apparent that the task force has a strong bias against screening or preventive medicine of any kind. Of course, nobody should be coerced to be screened. It's a personal decision, but impediments to access must be removed to provide equity in saving lives. And no woman should ever be put in a position of having to debate with her doctor, who's been misinformed by the task force, so that she should be able to actually access screening. Thank you.
Thank you, Dr. Yaffe. Next, from the Canadian Society of Breast Imaging, Dr. Kulkarni. Welcome to the committee. You have the floor.
Thank you. Honorable Health Committee members, I am grateful to have this opportunity today to talk to you all about breast cancer screening, a topic that is very close to my heart. I am an academic breast imaging radiologist working at the Princess Margaret Cancer Centre in Toronto and currently serving as the president of the Canadian Society of Breast Imaging. I am greatly invested in improving patient care and experience through the healthcare system. The recently issued Canadian Task Force recommendations that excluded screening of eligible women between 40 to 49 years came as a huge disappointment. The recommendations conflict with those of other reputable organizations, leading to confusion among healthcare providers and patients. Canada's evolving ethno-racial landscape has been systematically excluded by the task force recommendations, which are still predominantly based on older studies involving white women. The data is not fully representative of our population, leading to recommendations that might not be applicable, beneficial, or safe for everyone. For example, Black women experience poor breast cancer survival rates. They are more likely to be diagnosed with advanced stage breast cancer and have a biologically aggressive tumor, all of which occur at an earlier age than white women. Canadian data shows significantly higher proportions of stages 2, 3, and 4 breast cancers occurring in women in Canadian jurisdictions that do not include women in their 40s in screening programs, as opposed to those that do. Lower stage means less aggressive treatments, less side effects, and increased disease-free survival. Stage matters. Modeling has shown by not screening women in their 40 to 49 age group, we would see an additional of 470 plus avoidable deaths every year. This is equivalent to allowing a passenger jet full of young Canadian women crash every year because we refuse to screen them at the right time. This is the chilling reality of the situation. Mammography is a compression technique. Tissues overlap, and up to 16% women who come for their first mammogram are likely to be recalled for additional pictures, ultrasound, and sometimes end up with a biopsy with benign diagnosis. This percentage drops over the subsequent years. Recalls are not harms. These are like sending your bag through the airport screening. Most of the time, it goes through. Sometimes it gets pulled out, opened, checked, and given back. And occasionally, a forgotten nail clipper gets thrown out. Most women are grateful that they went through the one extra step for safety. The task force recommends shared decision-making to allow women discuss with their primary care providers the age at which they should have a mammogram. In a country that's grappling with severe shortage of family doctors, this is only a distant dream. The power differential between the physicians following the task force guideline and the patient is a barrier in shared decision making. The current tools provided by the task force are biased towards not having a mammogram. Among other recommendations, the task force recommended against supplemental screening for women with dense breasts. We know that dense breast tissue precludes finding breast cancers at an earlier stage, akin to finding a snowball in a snowstorm. This often leads to delayed diagnosis, greater stage and spread of cancer, more extensive and expensive drugs which may lack funding. These drugs can have a devastating side effect which significantly diminish quality of life and function. The task force has stated that there was insufficient evidence to support supplementary screening and selectively chose to follow the US task force on the dense breast recommendations. Meanwhile, there are decades of data that demonstrate the benefit of supplementary screening. More recently, Ontario Health conducted a health technology assessment and drafted a recommendation to publicly fund supplemental screening. To conclude, we want guidelines based on new and inclusive science that are aligned with other international guidelines and that consider the changing landscape of diversity and ethnicity in Canada. Early detection with novel personalized therapies is the best we can give women in their cancer journey. No woman should be denied a mammogram. Self-referral should be allowed. And for those women who prefer not to have a mammogram, they should be free to opt out. Thank you so much.
Thank you, Dr. Kulkarni. We'll begin now with rounds of questions, starting with Ms. Vecchio, please, for 6 minutes.
Thank you very much. It is absolutely wonderful to have both of you here today. I want to start off with Dr. Martin Yaffe. I thank you very much for the information that you've provided, and I want to go back to the task force. The fact that the task force members, who, what, where, and why. Can you start telling me first, how are these members appointed to the task force? How are they chosen to be the representation of the Canadians on this task force?
Well, that's a very good question. I'm not exactly sure how they're all appointed, but certainly some of them are appointed from the through the Canadian Family Physicians College, and there are other bodies as well, I think, who recommend individuals. What I've noticed, though, is there tends to be over time a kind of how can you put it, maybe a concentration of people who are like-minded, and the like-mindedness tends to be an attitude that less is more, that somehow just when you find a cancer, a woman finds a cancer, treatment alone, even if the cancer is found at a relatively advanced point, is adequate. So there's kind of a mindset that has accumulated, and it's been concentrated within the membership of the task force so that they tend to be like-minded on the subject and demonstrate a fairly clear bias against screening.
Thanks very much. And back to you on this, because when we're talking about that screening, we have heard, like many of you who have come to this committee, sharing with us that this should be lowered down to the age of 40. 40 to 49 should be included up to 74, and we may see that expanded as well. But going to you, looking at this issue, you're not part of the task force, but did you have a role to play when reviewing this information to provide your own recommendations? And from that, what type of information did you get back on for feedback?
Well, as I mentioned, I've been at odds scientifically with the various task forces since 2011, and I found that they've been very resistant to receiving information from experts like myself, like Dr. Kulkarni, Dr. Seeley, and others who are aware and very familiar with the scientific literature in the area. Instead, they've really focused narrowly on these old studies, which, because they're randomized trials, which is a great way of doing a study, but they're so old that they're not relevant. I think I may have drifted a bit from your question, so if you perhaps if you don't mind just repeating the last part of it, I want to make sure I answer you.
No, actually, you're answering that's where I wanted to go. I just wanted to know whether or not you had the opportunity to review some of these things. As you said, you have not been in agreement since 2011. So if we could just put it on the record, would you like to see these recommendations all reversed then that have come out from the task force?
Oh, absolutely. I agree with the other witnesses who have basically recommended strongly, based on the science, that women should have unfettered access to screening as of age 40. There should be strong consideration of continuing that screening beyond age 74, as long as women are otherwise in good health. And that's all backed by the modeling that I mentioned. There is at least the capability or the possibility of saving 1,000 additional lives in Canada every year if we did these things. Screening women in their 40s, extending screening beyond age 74, and also doing supplemental screening for women with dense breasts who basically for whom mammography is not going to work all that well.
Awesome. I want to switch over because I just have a quick question then for Dr. Kulkarni. Thank you so much for talking about this. I really liked your analogy comparing it to the airline screening. I always wonder if I've left that water bottle in there. So you get that anxiety, but the anxiety is sure a lot better than what else could happen. And I think that's what we have to see as for women. When they're talking about the harm being the anxiety, we can deal when we actually have solutions. And so I think by having this early detection, being able to have women go in there, that'd be really important. I want to ask you specifically because we are talking about the ages from 40 to 74, and I wanted to get your opinion on 75 and older and what that should look like. I have a mother-in-law who is phenomenally in great shape. I expect to have her around until she's about 120. So what do we do for those women over the age of 74, though, that are in just exceptional health?
We see that all the time. Like there are people who come for screening, and this is a very common comment that these people are healthier than me. So, as long as a woman is healthy, active, and has at least a 7+ year life expectancy, they should continue to screen. And that's what we are all recommending as part of, organizations. And those are the recommendations, that they should continue screening. And the program should allow these women to come into the screening program.
Wow, I still have time. Thanks so much. Oh, great. Okay, so I'm going to go back to you then as well, because we talk about the screening and recognizing the dense breast, recognizing that makeup ethnicity may also have a change to the composure of one's breast. What do you think? I heard someone say about ages 25 to 40. What should we be doing for those women who are ages 25 to 40 prior to having an actual physical screening?
So at the current time, there is a lot of discussion about risk assessment. And so it's been generally recommended, even by the NCCN guidelines, that women who are between 25 to 30 years of age can get their basic risk assessment performed. They are not yet at the age where systematic screening is offered, but they should at least get their risk assessment performed, so that in case there's a flag that this person is actually high risk, then appropriate steps can be taken. High risk women generally get screened much earlier than the average risk women. So that's what we want to offer to all these young women.
Thank you, Dr.
May I add
Kearney?
something to that?
Very briefly,
We do have a program in at least one province, Ontario, for women who have been identified as being of high risk, and those women are eligible from age 30 to receive MRI and or ultrasound, which are more accurate for women at high risk.
Thank you both. Next, Dr. Hanley, please, for 6 minutes.
Thank you. Thank you very much to all the panelists. I also want to acknowledge the courage of my fellow panelists for speaking up. We don't often, I don't think we hear enough in general from people with lived experience, and to hear testimony from panel members themselves, I think is extremely powerful. Dr. Yaffe, I'll go back to you, but I'd appreciate brief answers with full respect, because I'd love to spend hours on this, but only have 3 minutes. I'm going to share some time with my colleague, Dr. Pawlowski. But randomized trials versus observational. What I'm taking away is really we can no longer do those randomized trials that were done in the 50s and 60s, because it wouldn't be unfeasible to carry to do a control and a test group, let alone the evolving technology. So. In other words, we can't really replicate those previous gold standard trials. So do you favor that what the U.S. approach was to kind of understand the basic concepts and then move on and use only modern trials 2016 onward, even though most of them are observational. Could you quickly comment on the sort of the merit of that approach?
Absolutely. So randomized trials have proved the principle, but the technology used is no longer representative of current practice. Observational trials allow us to be more quantitative and use modern data to show what the possibility of mortality reduction is. And modeling will allow us to go beyond that and extrapolate from what we've learned in the randomized and observational studies.
Good segue, because I was going to ask you, based on the premise that all models are wrong, but some are more useful than others, could you defend your modeling practice? And I think you alluded to its compatibility with other modeling exercises, particularly in the U.S.
So it's not my model. It was developed by Statistics Canada in partnership with the Canadian Partnership Against Cancer. It's a wonderful model, and it actually is available for multiple cancers. It's been validated against empirical data, against actual measurements in the public. And we compare it to the U.S. models, of which there are 5. Actually, one of the models is from the Netherlands. So we always cross-compare against models, and they tend to agree with each other, which is great. And that gives us more confidence in their validity.
Thank you very much. Dr. Kulkarni, so many questions to you. I'm going to limit it to one. I believe the European recommendations are 45 onward.
That's correct.
Can you comment on that versus the U.S.? Has Europe, is there a difference in the methodology there or the basis for conclusions?
So different organizations tend to have a little bit of variation whether to start at 40 or 45. And we certainly see that even in some organizations in the US, like the ACS recommends at 45. And I think we have some provinces here in Canada that also recommend 45 and above. So there's a little bit of variation. But overall, if you look at all the evidence that is currently available, it is best practice to start screening at 40. And that's what we are pushing for.
Thank you. I'm going to hand over to Dr. Pawlowski for the remainder. Thank you.
Dr. Yaffe, were you yourself an expert, subject matter expert advisor to the task force?
No, I wasn't. I was invited by the Ottawa Evidence Synthesis and Analysis Center to advise them. But as I mentioned, and Dr. Seeley mentioned, we both worked with them. There was interference by the task force on what that group was allowed to do.
Now, am I right that anyone who dealt with the task force had to sign a confidentiality agreement as part of working with the task force?
That's correct. And that's one of the reasons I wasn't willing to work with them directly, is I wanted to be able to speak freely.
To your knowledge, the people that work with them directly, did the task force follow the advice of its own experts? And we've already had Dr. Seeley saying, no, they didn't. But I know she can't talk for the other experts, and nor can you. But to your knowledge, did they follow the advice of their own experts?
I really don't know. I did speak with one of them who informed me that he felt that his interaction with them was minimal. He didn't understand much of the decision-making process, and really didn't feel that he had much influence on the process.
Is this troubling to you, that in a matter so important that people who are advisors are forced to sign a confidentiality agreement and therefore can't really make public what they told the task force?
Well, sometimes there are confidentiality agreements that are limited in time, and there's sometimes reasons for that. But I did feel that the restriction, especially when the whole process was one that I found very difficult to understand and agree with, I found that was very problematic. Why should we be looking at evidence, at studies that were done 60 years ago that are completely unrepresentative? That's just makes no sense at all.
Lastly, the allegation by those probably on the task force, and the reason probably they gave for putting non-subject matters as part of the task force making the decision is that they they didn't have any personal financial interest in the outcome. And I know some on taking the other side are going to say, well, of course, radiologists want to do more mammograms because financially they make a fair bit of money on mammograms. Do you want to just formally reply to that, either Dr. Yaffe or Dr. Kulkarni?
A brief
well,
response,
I'll just
please.
say I'm a PhD. I get a salary for doing research. So the amount of screening that takes place really doesn't affect my personal life.
Thank you, Dr. Yaffe. Suite, Monsieur Thériault, pour 6 minutes, s'il vous plaît.
To be followed by Mr. Thériault for 6 minutes, please. Thank you very much, Chair. I would like to put my question to Mr. Yaffe. Jacques Simard, who is the Vice Rector of Research at the Faculty of Medicine at Laval University, suggests that without changing the age of screening for everyone, women should nevertheless receive personalized follow-ups based on their risk levels, taking into account, more specifically, breast density, their age, and family history. He suggests that those that have normal risk continue to undergo mammography every 2 years between the ages of 50 and 72 years, whereas those who had a higher risk begin annual screening in their 40s. And those that have high risk could also receive both ultrasound and MRIs on an annual basis. What do you think of that recommendation?
It's a very interesting recommendation, and I respect Dr. Simard's work very much, but I don't think at this point we have validation that it would work. In other words, in order to screen people less frequently, we have to really know that that the risk of developing cancer is so low that they're not going to have cancers missed because of that policy. And that has not at this point been validated. And most individuals don't express risk factors for breast cancer other than being female and getting older. So yes, a great idea. I think in the future this may be something we do, but we're not ready for that at the present time.
Merci.
Thank you. The chair of the Canadian Task Force on Preventive Healthcare stated during a press conference when the recommendations were updated and made public that it's not because there's more cancer that we need to carry out more screening. We need to ask, why are there more cancers in the population? So what do you think of that statement?
Was that for me or for Dr. Kulkarni?
For you, sir.
Thank you. I think that it is important for us to understand the causes of cancer and to continue to look for means for preventing cancer. We know that there are some issues around alcohol consumption. There are lifestyle issues, obesity, et cetera. But at the same time, I think prevention and early detection and treatment are not competing with each other. While we're learning how to prevent cancer, we should do what we can to prevent women from dying from breast cancer. And in fact, screening is often referred to as secondary prevention. We're preventing advanced disease. If we find it earlier, it's treated much more successfully. It's better for the patient. It's also better for the healthcare system because research that's about to be published shows that the costs go down as you do more screening because you have fewer advanced stage cancers that need to be treated.
Merci beaucoup.
Thank you very much.
Vous avez encore 2 minutes, si vous voulez.
You have another 2 minutes if you wish to use them. Oh, all right. I will be very happy to continue. Yes, you have 6 minutes in total. A number of experts criticize the effects of false positives resulting from screening, and based on that, are unwilling to recommend systematic preventive measures for women in the 40 to 49 age group. What do you think of that? Could you tell us more about that?
Question, was that about, I thought I heard in French false positive. Is that what you're talking about?
Oui.
Yes, indeed. Some experts, in fact, many of them say that false positives are a very bad effect, have a very bad effect, and therefore we shouldn't screen. Please, your response.
Yeah, first of all, I think we need to get away from the term false positive. It's completely a misnomer. false positive implies someone has said somebody has cancer when they don't. What the term really refers to is, as I think Dr. Kulkarni mentioned earlier, is that women are asked to come back for additional imaging to make sure there's no cancer. So the first screening exam is not absolutely clearly negative, so they want to make sure that they don't miss a cancer. Yes, if it takes a while before the answer to that additional imaging comes out, there will be some anxiety. Much of the research shows that that anxiety is transient. And as Dr. Seeley mentioned, patients are generally much happier to accept that anxiety as opposed to the chances of a missed diagnosis of cancer and the need to treat advanced disease. So I think the task force is really off base in terms of considering that as a harm. It's something we should try to reduce the anxiety, not reduce the detection of the cancer.
Merci. Selon le...
Thank you. According to the Canadian Task Force, the risk of false positives or abnormal recalls are really so high that the advantages pale in comparison. Overdiagnosing, too many biopsies as part of the potential harms. Do you think we have overdiagnosing in the studies that were used to come to these conclusions?
Again, if that's for me, I've actually co-authored with a medical oncologist, Dr. Kathleen Pritchard, who's one of Canada's outstanding medical oncologists in breast cancer, a paper called Overdiagnosing Overdiagnosis. And the point is that some cancers will grow slowly, and some people will, if they didn't know they had the cancer, that cancer may not have bothered them before they died of some other cause. But the reality is that the fraction of those cancers, and these are real cancers, but they're cancers that perhaps grow slowly, the fraction of those cancers is relatively small. It's certainly generally under 10% and perhaps in the order of 5%. The idea is to avoid over-treating those individuals. So once a cancer is diagnosed, try to determine if it's going to be one of the aggressive ones or the less aggressive ones and make the therapy be suitable for the characteristics of the cancer. I think that's the right approach, rather than just not finding the cancer and playing Russian roulette with letting a dangerous cancer continue to grow.
Thank you, Dr.
If I may add there.
Very briefly, please.
I just want to echo Martin's sentiments that overdiagnosis is a word which is very difficult to understand. The role of screening is to find the cancer. How to treat the cancer is a different aspect of the cancer. And for us to determine which cancer is going to be biologically aggressive and grow and kill the woman versus which cancer is going to not grow and allow the woman to die of some other cause, this is something that we cannot tell just based on imaging. So it's not really overdiagnosis. We have to figure out which cancer needs treatment and which doesn't. That's not part of the screening process.
Okay. Thank you. Ms. Zarillo, please, for 6 minutes.
Thank you, and I really appreciate those comments by Dr. Kulkarni, because in modernized cancer treatments, there are so many more options, so I really appreciate that. It was a year ago, exactly, that Minister Duclos announced up to $500,000 in additional funding to the task force to help expedite the update of the breast cancer screening guideline. And he's quoted as saying, breast cancer screening guidelines that are based on the latest science is essential. Dr. Yaffe, I wonder if you think that this task force new guidelines are based on the latest science.
Well, I think that they would say that they have looked at the latest science, at least at some of the latest science, but because they've continued to focus so much on these 40 to 60-year-old studies, that raises concerns. The more modern data shows mortality reductions in the range of 40 to perhaps even as high as 60% for women who participate in screening, emphasis on the word participate, and also that the stage at which the cancer is found is earlier, meaning it can be treated more successfully and with better outcomes, less morbidity, and at lower cost. So I don't see that in anything that the task force has put in their literature. I've read their reports, and there's nothing that clarifies that they've really taken that more modern data seriously. And as mentioned earlier today, nothing on breast density, nothing on women who are who racialized, whose breast cancers tend to occur earlier. They tend to be more aggressive in some cases, and their outcomes we know are worse. They do much worse. So there's an inequity there.
Thank you, Doctor. And that inequity is something that I'm really concerned about, and I wanted to ask a question on that later, but I just wanted to follow up on this one. Dr. Yaffe, do you have any information on the parameters that the government gave this task force? Specifically, is there a cost-saving requirement? Is there an ROI that this task force had been asked to do in relation to women's health and breast cancer?
I don't know the answer to that question. I suspect that there is an underlying sentiment among task force members that spending less money on breast cancer screening will free up money to do things that they may be more interested in, but I don't know that for a fact.
Thank you.
But as I mentioned, what we've learned is there's actually a potential cost reduction associated with screening.
Thank you. And I'm going to ask Dr. Kulkarni the same question, just about, do you have any information on the parameters the government gave the task force and anything that might be related to
I
money?
don't think this information is available to any of us from the outside. So I don't have any information. But just to address another thing that was brought up is mammographies actually don't pay that well. So that this is a misconception that reading more mammograms is an easier job. For example, a mammography would pay 10 times less than what a CT scan would pay. So anything related to women's health is really not that well reimbursed. So you can say that there's another problem right there. It's not being prioritized.
Yeah,
but
and I
appreciate
that. I appreciate that, because also to the work of women not compensated properly either in the medical industry. Dr. Kulkarni, I wanted to ask you about the what expertise do you believe needs to be included in the task force with a back to the drawing board recommendation that could come from this committee?
So basically, they had invited some advisors. We heard from two of them today in the evidence review. There are some other advisors that were working directly with the task force. So all of these people need to be talked with and find out if the decision that was made, the draft recommendations, is that a unanimous decision? Were there any people within the team that felt that this was not okay to do? So that's one thing. Second thing, as we saw, that these recommendations cannot go forward as they are. They need to be reversed, or they need to be at least temporarily stopped till the investigation is fully over. And people should be encouraged, all family physicians should be encouraged to follow provincial guidelines for the time being till this is resolved. Because rolling it out the way it is going to be detrimental to the country.
Thank you. With that, Mr. Chair, I would like to ask that this committee ask Public Health Canada and the government to supply to this committee the parameters that were given to the task force for their updated study. I also have another question, Dr. Kulkarni, just around, actually, Dr. Yaffe said it, but this debate with the doctor, that was certainly my experience as a dense breast woman. I had to have a debate with my doctor for 2 years, and I worry about non-white, as was mentioned earlier by Dr. Seeley, how much they would have to debate and fight with prejudice and bias. So I'm wondering if you wouldn't mind sharing how we can overcome that bias at the doctor's office.
So first of all, public education is very important. I think we are not spending enough dollars in actually informing people. We have a huge population now, which is very diverse, and we are not addressing that. And the most important thing is the guidelines. The guidelines have to endorse that we need to do this, and that is followed by capacity. The wait times in our country are horrendous right now. And that does not allow us to open up our doors to more and more ultrasound screening. So it's a huge capacity issue. And so there's a lot of work that needs to be done so that it can be equally available to everybody without them having to fight for it.
Now, I don't remember seeing that in the task force.
Okay. Ms. Cirillo, thank you, Dr. Kulkarni. That's your time. Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here. It's refreshing to hear common sense solutions being brought forward here. And as I've done so much research into this over the course of this brief study, there have been so many different organizations that have very quickly come out being opposed to these guidelines. Dr. Kulkarni, would you like to see the reversal of the task force guidelines? Would that be your recommendation?
Yes.
Thanks. I appreciate that. So it is, to me, apparent and obvious that there are very serious issues with the task force guidelines. This week we've heard evidence pile up from a variety of experts, and I think it's important as such. And so I'm going to look for unanimous consent to move the following motion. Given that the federally created Canadian Task Force on Preventative Health Care decided not to lower the breast cancer screening age guidelines, and that Breast Cancer Canada said that it was, and I quote, deeply concerned by the task force guidelines, the committee reports to the House that the decision by the Canadian Task Force on Preventative Health Care should be immediately reversed, and Breast Cancer Canada's screening should be extended to women in their 40s, as this will help save lives.
Unanimous consent is not required to present the motion because it touches on the subject matter at hand. So the motion is properly before the committee and is in order, and the debate is now on the motion. Dr. Hanley?
Okay. I thought I saw Dr. Ellis's hand
Sorry?
first. I thought I saw Dr. Ellis's hand first.
Oh, I saw yours first.
Okay.
Sorry,
Then
Mr. Chair, I was
happy.
not. I asked for unanimous consent, and
You asked for unanimous consent to move the motion, and you didn't need it.
to pass the motion.
That's not what you said.
Sorry.
Okay, so you're looking for unanimous consent on the motion. Does Ms. Goodridge have unanimous consent to adopt the motion as presented? No. Okay. You do
So,
not have
Mr. Chair, let me get this straight. We've heard from countless.
No, you don't have unanimous consent. It appears that there's a willingness to debate the motion. Is it your intention to withdraw the motion, or are we going to have a debate on it? All right, Dr. Hanley, Dr. Ellis, Ms. Goodridge.
Yeah. So I accept the motion. I just don't feel comfortable with the recommendation, because I am not sure that although I do think that ultimately we need to get to a place where we have a uniform recommendation on screening. I'm not sure that we can direct an independent task force as to what to conclude. I think we have to find a way to advocate for guidelines and advocate for family physician education. So I think my interest is in getting to the same place. I'm not sure that this is the correct process to do so. Thank you.
Dr. Ellis?
Well, thanks very much, and certainly, I respect Dr. Hanley's comments on this. I think the difficulty is we've heard overwhelming evidence in this committee, and certainly it's piling up by the minute. We have, one of the world's foremost experts, Dr. Yaffe here, who has worked on this around the world for, as he said himself, 44 years. We know very, very clearly that the evidence would suggest that women should be offered screening for breast cancer between the ages of 40 and 79. That means that women would have access without having received mixed messages, that it would be an incredibly strong message from this committee to tell the task force that what they have concluded is incorrect. I realize that many of us sitting around this table may not be scientific experts, and certainly I realize we're not on the committee. The difficulty, as we have heard very clearly, though, is continuing to allow a task force to operate in a manner which is disrespectful of science and anti-screening, anti-prevention. I think that those are words that are not too strong. We've heard them repeatedly here. That continuing to allow a task force to operate in that manner is reckless, and especially when we have also heard that 1,000 women will die based on the reckless nature of Canada's preventive healthcare task force. And that is something that I realize perhaps many would argue that is not in the purview of this committee or of the federal government. However, I think that the important fact that we need to remember is that this committee can have an incredibly loud voice out there on behalf of Canadian women who will die in numbers that they shouldn't because of inaction or inability or perhaps ignorance of a committee that really does not want to consider the science. That is dynamic, that is changing, and for those of us, I was a family doctor for 26 years, and realizing that science does change is an important aspect of providing excellent quality health care. I think the other important thing is for the Canadian Task Force on Preventive Healthcare to come with a bias, as Dr. Yaffe had suggested, and other witnesses have suggested, to come with a bias against screening and prevention is a non-starter. It's illogical to think that a committee based on preventive health care would have a bias against screening. That is nonsensical. And then, of course, to not allow women to make well-informed decisions based on a discussion that they can have with their health care provider is incredibly misogynistic, in my opinion. Of course, as I said, clearly I'm a male, former healthcare provider, and to not allow women to have that opportunity to have that discussion is problematic for me, and to allow that to not exist is something that is going to result in the death of more women is absolutely intolerable. I will state for folks that this is an incredibly personal thing for me. My wife had breast cancer diagnosed at age 48, and thankfully she has made it past her 5-year mark and has made a fantastic recovery. So that being said, it is not just science, it's personal, and we look at the potential years of life lost for young women who are not able to access screening. And as our colleague from the NDP has mentioned, women from marginalized, racialized, often remote and rural communities not having this access. And you know what really struck me from our colleague from the NDP's testimony was the fact that she was a 48-year-old white woman who had to fight for herself. And I can only imagine, certainly from my perspective, what it would be like to be from a racialized community and having to attempt to advocate for yourself when the Canadian Task Force on Preventive Healthcare has said that you are not able at age 40 plus to access breast screening for breast cancer. I can't imagine how much of a daunting task that would be. In fact, I would suggest that it becomes an impossibility to advocate for yourself against a system in which the cards and the deck are already stacked against you. So perhaps, as my colleague Dr. Hanley suggests, that this isn't quite exactly the way it should be. But I think that if we do not come forward with an incredibly loud voice, as I suggested with the last panel, that the likelihood of the task force succumbing to anybody else, I mean, my goodness, if we have someone like Dr. Yaffe here suggesting that this needs to be changed, that the likelihood of the task force changing course and agreeing with him is probably slim to none, so that if we do not make incredible amounts of noise about this on behalf of Canadian women, then I think that we are doing it a disservice. I think the other things to really consider is when you look at the amount of press being played towards this, that it's incredibly important that the media understands the decision that is being made here and how important that is, that the task force is going against new evidence, that our neighbors to the south, the U.S. Preventive Task Force, has agreed that the evidence is there, perhaps, as Dr. Yaffe suggests, not to age 79, but certainly between 40 and 74, with the option for women over 74 to have screening based on, as Dr. Kilcarn said, based on their overall level of health. I think that makes perfect sense as well. But for us to not make a loud noise about this when we have had the overwhelming amount of evidence to the contrary, I think that we are doing Canadian women a disservice. And I certainly don't want to be a part of doing Canadian women a disservice. And I would urge my colleagues, in spite of the fact that their belief is that this is not at the appropriate table to make this call, that they reverse their decision and they support my colleagues' motion put forward, asking for unanimous consent to support this motion. I think that science is against you. I think that public opinion is against you. And I think that history will stand against you and say that the decisions that you have chosen to make here are inappropriate. I want to be clear. I like my colleague, Dr. Hanley. I respect his decision. But that being said, if we do not make a loud noise about this, the difficulty that will persist is that we will continue to send mixed messages out there to provinces and to Canadian women, and Canadian women are going to die because of that. And that's not right. It's not right. It may not be exactly in our purview, but certainly it is within our purview to say that we categorically do not agree with the decisions that have been made, that their decisions should immediately be reversed, and breast cancer screening should be extended to women in their 40s. Honestly, I've asked other panels here today how best they think that we could make a loud noise with respect to that, because I believe that that is exactly what needs to happen. This needs to be a loud noise. It needs to be definitive. We need to call out a task force that is not respecting the science, that refuses to respect the science, that we know from other task forces in the United States and Europe that they have chosen to not require randomized controlled trials because we believe that that part of the science has been settled, that we need to move forward and understand that we have new methods of diagnosis, new methods of treatment for breast cancer, and that those new and best methods need to be respectful of Canadian women. I don't think that I can state it any stronger than that, Chair, that I urge my colleagues to accept unanimously this motion put forward by my colleague from Fort McMurray Cold Lake on behalf of Canadian women who are dying senselessly because of the inaction and the ineptitude of the Canadian Task Force on Preventive Health Care. Thank you, Chair.
Thank you, Dr. Ellis. Ms. Goodridge?
Thank you, Mr. Chair. I would hope that we can just get to a quick vote on this and get back to the committee business. I think it is very troubling that members, particularly Dr. Hanley, who is a medical doctor, wouldn't vote in favor of this after all of the testimony we've heard here, but I'm really hoping that we can get to a quick vote on this.
Dr. Pawlowski?
Generally speaking, I'm in favor of this issue. However, and I've been involved with this a long time. Dr. Yaffe and I think spoke about this first a number of years ago. Don Davies, let me give a shout out to him with the NDP, also has been very involved with trying to get this issue addressed. I do have some concerns, as with Brendan, with a parliamentary panel of admitted non-experts trying to overturn the decision of a body, albeit seemingly flawed body, like the task force, and trying to overturn their decision. I think as much as possible, and certainly in my life, I separate the medical because I still practice medicine. I separate the medical from the parliamentary, and I think that's important. We're not experts. I would suggest, and I'm just throwing this out because we haven't had time to fully consider the whole thing, but I wonder if there would be an appetite to amending the motion to read this. And again, I haven't cleared this even with my own party, but I'm suggesting there would be a more of an appetite to this wording. Given that the federally created task force on preventative health care decided not to lower the breast cancer screening age guidelines, and that Breast Cancer Canada said it was deeply concerned by the task force's guidelines, the committee reports to the House that the decision by the Canadian Task Force on Preventative Health Care should be immediately reconsidered and breast cancer screen and consideration be given to extending breast cancer screening to women in their 40s, period. I think that would perhaps strike a better balance between these two concerns about a parliamentary committee overturning or making an attempt to go where perhaps it shouldn't. But having said that, I think I agree. We've heard some compelling evidence on this, and certainly there's enough expertise here that suggests this decision ought to be reconsidered. I think this would be a better balance myself. So I don't know if I have to make that a formal motion to amend this, or if we need to pause for 5 minutes for parties to consider this.
Mr. Chair, I'll accept that.
Okay. So I think it would be best that you formally move the amendment. It appears that the Conservatives have already made up their minds on it, or at least one of them. So I'm going to take that as the motion being amended. And the amendment is to change the word reversed to reconsider, and after the word screening, to the wording will now be consideration should be given to extending to women in their 40s, as this will help save lives. So I think that's the essence of what you've suggested.
I think the wording at the end, and consideration be given to extending breast cancer screening to women in their 40s. I would probably, or if you want to save lives, as this will, in the committee's opinion, help save lives. I just don't want to, again, because there's an interpretation of the evidence that we're not experts in. So I would either drop the as this will help save lives, or in the opinion of the committee, this will help save lives.
Okay, the amendment is in order, so the debate is now on the amendment. I see Dr. Ellis. We did have a speaking order on the main motion, but the speaking order resets, so if you want back in, put your hand up. Dr. Ellis is next.
Well, thanks very much, Chair, and I thank Dr. Pawlowski for that. You know, certainly changing the wording is somewhat watered down, absolutely. But given that, I think that it's incredibly important that we move on this sooner than later, and I would hope that my colleagues would support the wording change. I know that here on this side we would be supportive of that. Because we can't move fast enough to make this happen. This has been a dilly-dally committee, not this committee, the task force committee has been a dilly-dally committee that has known this evidence for some time now. I don't think that suddenly in 2024 that this is a sudden thing. I think it's the inaction and the inability to hold the Canadian task force to task is what has allowed this to continue and has allowed thousands of Canadian women to die every year needlessly. So time is of the essence, folks. Let's show our colors and support this motion. Thanks.
Yes, Ms. Cirillo?
The amendment, please, in writing.
Yeah.
Sean, can someone do that? I have to type on my little thing here. You're probably someone's quicker than me. But.
Okay. This, it's going to require suspension in order to get the wording and get it translated. So I think what I'd like to do is to dismiss the witnesses and then tend to getting the amendment circulated. So to
Sean, can witnesses stay online if they're interested?
Absolutely. This is one of these you're welcome to stay, but you're free to go scenarios. So to each of our witnesses, thank you. Yes.
Oh, I'm sorry. Point of order. Before you suspend, I just wanted to have a chance to float the wording that I had, which is very similar to Marcus's, but I think before we get into a sort of a written.
That's not a point of order.
We would need to defeat his. We could do a sub-amendment, or we could defeat his amendment and then propose a new one. Those are your two options. So that's something that perhaps could be discussed on the suspension.
It's only that since it isn't in writing yet, and Marcus isn't sure of his own wording, I have a refinement to it.
Well,
I'm happy to do it as a sub-amendment. I want us to get to a place where we can all.
You and Dr. Pawlowski should talk. Okay, to our witnesses, we will not get back to you today. You are welcome to stay, but you are free to leave. We greatly appreciate you being here. You can see that you've sparked a spirited debate, and a debate that needs to be had. We thank you for your work, and we thank you for your presence. And as I indicated, you're free to go, but you're welcome to stay. We're going to suspend in order to get the amendment in both languages and in writing to the committee. The committee stands suspended.
Thank you so much.
have the amendment available for distribution in both languages, but during the suspension it was agreed that we're ready to recommence. So where we left off, the debate was on the amendment proposed by Dr. Pawlowski, which was as follows: after the word immediately, that the motion be amended to read, reconsidered, and breast cancer screening, and consideration should be given to breast cancer screening being extended to women in their 40s, as this will, in the committee's opinion, help save lives. Okay, slightly different. Let me start that again. The amendment is to delete all the words after the word immediately in the motion and to replace them with the following: reconsidered and consideration be given to extending breast cancer screening to women in their 40s, as this will, in the committee's opinion, help save lives. Where we left off, Dr. Ellis had the floor, and so I recognize Dr. Ellis on the amendment.
Thanks very much, Chair. You know, certainly the concern I have with that is it's a somewhat watered-down version, and I think we should move to a vote on it as quickly as possible.
Monsieur Thériault, s'il vous plaît.
Oui, Monsieur.
Mr. Thériault, you have the floor. Thank you, Mr. Chairman. I know that we're running out of time, and I'd like to move this forward. I am in agreement with the motion for its basic content. Often we go into a committee and we come up with a report and we make recommendations, but I certainly understand that given the urgency of this matter, we are making a recommendation here today and intending to make it in the House, not necessarily providing a detailed report to cover all the arguments behind our recommendation. I'm not too worried that I'm not an expert. If we had to wait for experts to make recommendations, then no committee would be making recommendations. So that being the case, I agree to moving forward with this. We rarely see all witnesses holding such a clear, unanimous opinion and point of view, expressing a point of view so clearly. And I put all my questions. I got very clear responses from all witnesses, no ambiguity. That's why I agree with the grounds of our undertaking, even though it is an unusual approach at the end of a session to be bringing something of this nature before the House. But I have no problem with what I see before me right now, the wording. And indeed, I'm sorry, but on Mr. Pawlowski's motion, so I would return to the original motion for the reasons that I provided. I'm perfectly comfortable making such a recommendation, even though I'm not an expert. It's quite clear that the committee is making its recommendation. We are not executing on this. The government may make what use it sees fit of our recommendation.
Mr. Hanley, please.
Yeah, I support the amendment, and I agree in principle with what Mr. Thériault is saying, and I want to make it clear again for the record that I would love us to all get to a consensus to make this unanimous so that we can express the urgency. I have no problem making the noise. I have no problem with the urgency of this, but I think we just have to respect the proper process. The minister doesn't direct the task force. Neither do we direct guidelines, or as politicians, we are not responsible for issuing guidelines. But we can ask the task force to consider to urgently review with a view to arriving at a recommendation of screening for women 40 plus. So I think the goal is to get there in an expeditious way. Hopefully we can all agree on that by following due process. Thank you.
Thank you, Dr. Hanley. Ms. Zurillo, please.
Thank you. We're going to go to a vote. I was on the list for the other one, so we'll just go to the vote and then we can talk about.
Ms. Roberts is left. She was next. After Ms. Roberts is Mr. Naqvi.
Thank you very much, Chair. And this is a very important topic. It impacts a lot of women in this country. I think the mark of this committee has been to do thoughtful work, thoughtful analysis. I'm sure that we all agree on the recommendation that we will be making through the work this committee has been doing. I think what saddens me at this moment, by the original motion and the sub-amended motion, which I support, that we're basically writing the report through by one motion, and we're really missing the opportunity to capture pretty much the unanimous analysis that we received from some incredible witnesses. And I think the value in capturing and documenting the witnesses' testimony is getting missed by using the process that we're using and getting a more substantive document in front of the task force in their 60-day review period that has been extended as the minister have asked them to do so, by just basically having a 5-6 line set of recommendations. So that's my concern. I think that's what Mr. Hanley was referring to as well in terms of shortchanging the process. I don't believe in being loud for the sake of being loud when the being loud does not backed up, not substantiated by a rational thought process. I think being loud is far more effective when you can justify why you're being loud, and I think we're just missing that opportunity in terms of writing a report that analysts would have captured by hearing the kind of testimony. But in any case, I support the amendments that have been put forward, and so that we can really help ensure that we are moving forward with ensuring protecting women's lives, lives of women, especially as we heard, who are racialized. I come from that background. I've just talked about the experience I went through with my mother, who's an educated woman. All of us are, but the kind of anxiety that we face as we worked through that process. But I think we should do so in a way that really is fitting of this parliamentary committee. Thank you.
Ms. Vecchio?
Read it, but I thought Sonia instead put up her hand. So
Ms.
sorry.
Sidhu? Ms. Sidhu?
Yeah, thank you, Mr. Chair. I agree with the proposed amendment. We heard Mrs. Azarilo's testimony, and thank you, Ms. Goodridge, your work. And we all agree that my mom is also fighting with the cancer. We have so many, we also, members are agree with the amendments. But we also heard the testimony, so I know this is not how we are writing the reports. I would like to remind members opposite what we have, how we are writing another reports. Also, we are discussing in FIVO too, and where we're going to listen even more witnesses, and then we can come up with I think a more exclusive report. This is something I want to urge, and then if we are agree with everyone, we have same views, why cannot we listen more witnesses? This is just my urge to the committee.
Okay, I believe the speakers list is now exhausted, so we're ready for the question. The question is on the amendment proposed by Mr. Pawlowski. All those in favor of the amendment, please raise your hand. All those opposed? The amendment is defeated. We're now on to the main motion as presented by Ms. Goodridge. Ms. Zarillo, please.
Thank you, Mr. Chair, and I really appreciate the opportunity to have this discussion today, and I do appreciate the motion put forward in relation to fast-tracking this. Some of the previous discussion that we just had reminds me of the 2 years that I had to fight my own healthcare provider to try to get heard and seen. And I feel a sense of some of the underlying messages that the Liberal Party was trying to send, that asking for women's health to be prioritized, asking for women's health to be seen in the House of Commons is not rational. And I fundamentally object to that. So I do have an amendment that I would like to move today, and I hope it can be unanimous. I know that the health minister has already put forward directives on the draft recommendations from the task force. The health minister has a lot of power to ensure that women are seen, and I hope that we can move quickly on this and actually finally be at a point where women are seen in the healthcare system and by this government. So I have two amendments. One is guidance and following up to what my bloc colleague had to say about how many witnesses spoke today about their concerns. So after the wording deeply concerned by the task force's guidelines, I would like to amend that we add comma, and so were the majority of witnesses. And then after the wording as this will help save lives, to add and that the Minister of Health direct the task force to go back to the drawing board and revisit the guidelines based on the latest science, and that the Public Health Agency of Canada table to this committee the parameters given to the task force to update breast cancer screening guidelines. And I'll just remind the committee that the health minister did say, with the additional $500,000 that was given to this task force, that his expectation was that the report would be based on the current science. Thank you, Mr. Speaker,
Okay.
Mr. Chair.
I just want to make sure that we have your amendment. From what I heard, it appears that your amendment is in order. So this is, yeah. So just give us a minute to distribute it, and I have Dr. Pelosi and Ms. Goodrich to speak to it.
I'd like to see the amendment before I speak to it.
Yeah, I think we all would. So that's happening as we speak.
Mr. Chair, point of order. I'm ready to speak to it.
Dr. Pelosi is next, and he's asked to see it. So we're going to respect that, and it's not going to take much longer.
Point of order, Mr. Chair. I appreciate that he is next. We have provided this to the clerk. I do have a printed copy for all those in the room. We have very limited time. I believe that this is a very common sense, reasonable proposal that's been put forward by Ms. Zerillo. It's clear that some members are looking to filibuster, and frankly, this is women's lives on the line, and so I'm just asking that we can move to a vote so that we can have some movement forward on this very important topic for women and all Canadians.
We won't be moving to a vote until the speaker's list is exhausted. It's been sent. Dr. Pelosi, I believe you should have the amendment now. You're on mute. So this. Dr. Pelosi, please go ahead.
I suggest that I'm going to Leila first while I read it.
Okay. Ms. Goodrich.
Thank you, Mr. Chair. I believe that this is the result of working across party lines, and I want to thank MP Zarrillo for working with both myself and Monsieur Thériault pour trouver une motion et une amendement.
To find a motion and an amendment that truly is responsive to the needs of Canadians.
You talk out the clock on this. We have a handful of minutes left. I'm pleading with committee members to just allow us to get to a vote.
Okay, we actually have resources until 2:30, and so a motion to adjourn can be presented at any time before 2:30, but if there isn't one, that's when we're going to cut off the meeting. Mr. Naqvi, Dr. Pawlowski, and then Dr. Hanley.
Thank you very much, Chair. The challenge I have with the amendment that been presented is that it is asking the minister to do something that the minister just does not have the power to do so. And I'm challenged that we approve a motion that is outside the scope of ministers' authority to do so. In particularly, the part that it says that the Minister of Health direct the task force to go back to the drawing board and revisit the guidelines based on the latest science. The minister does not have that authority to do that. I want to highlight for the committee that the minister has taken some very important steps in order to address this issue. And he did so the day the draft guidelines were issued by the task force. Among the steps he's taken, he has highlighted his serious concerns about the task force findings and have encouraged all leading experts on breast cancer to carefully review the draft guidelines and to provide their feedback to the task force during their consultation period. He have also called for an extension of the public consultation period from 6 weeks to a minimum of 60 days. So there is that sufficient time, that ample time for that to happen. Secondly, he's also asked the Chief Public Health Officer to convene a meeting of senior provincial and territorial officials and key experts to review the guidelines in order to share their best practices as well, which is an important step because, as we know, the delivery of healthcare takes place at the provincial and territorial level. Furthermore, the minister has also noted that in the task force has identified some important research gaps and uncertainties, and there are steps that he has outlined in order to meet those gaps. But lastly, the minister has also asked that the Public Health Agency of Canada accelerate the launch of the external expert review that will examine the processes of the Canadian Task Force on Preventative Healthcare and provide recommendations to improve the process of the task force so that we don't run into the similar issues in the future. And I think that's a really important step that the minister has taken because PHAC funds the task force, doesn't direct the task force, nor the minister directs the task force, but we need to make sure that if there are some systemic challenges in the manner in which this task force operates, as I think we are all seeing in this process, let's make sure that moving forward we don't run into this. So it's really to me the challenging part has been that we are seeing a motion that's being debated right now that is asking to do something that the minister does not a capacity to do it. But again, I think we all want to move forward with this. We want to make sure that if this is the will of the committee that we just move by way of a simple motion, then we should do so. But I think we should do so in a responsible way, in a way that is within the due process as the process works. So I do suggest and move that we just, instead of using the word direct in the motion, which says direct the Minister of Health, that we change the word direct to urge the Minister of Health. I think that change will allow the minister to do something that he is able to do and he has already spoken to, as opposed to asking him to do that he does not have as the authority to do so. This is a really important issue. This is an issue that is personal to so many Canadians. It's personal to members of this committee, including myself. This is not a political or partisan issue. And we need to make sure that we move in a way that is, again, fitting of this committee, and as has been said, and I agree with the members, so that Canadian women know that we are doing our work in a thoughtful and responsible way by making sure that their health is front and center. Thank you.
Okay, so now we have a sub-amendment to substitute the word urge for the word direct contained in the amendment. The sub-amendment is in order. The debate is on the sub-amendment, and the speakers list resets. Is there anyone? Dr. Ellis?
I think it's a bad idea. Let's get to the vote.
Dr. Pawlowski is got his hand up. Go ahead, Dr. Pawlowski. You have the floor.
Yeah, I'm speaking to the sub amendment, but through the sub amendment of the original motion. But I've got to say I am unhappy with the fact that my initial amendments weren't accepted. I think that was a good compromise. I think this motion, as it presently stands, is basically an attempt by a committee of parliamentarians to overturn the decision based by a medical task force, and albeit I see it as a very flawed medical task force, albeit I agree that I think they came to the wrong decision. However, I don't think it's the place of a bunch of elected parliamentarians to overturn or to try to overturn the decision of an expert task force. Just as it wouldn't be appropriate that we're telling farmers what kind of seeds to plant in the fields, or we're not telling roofers what kind of tiles to put on their roof, or telling airplane pilots how they should be flying their planes. There is, and we ought to be recognizing that there is a degree of expertise here that we do not have. I think the fact that we're coming down looking like we're telling them how they should be doing things, ordering them basically to go back to the starting table and to review the basic evidence. We are not better than they are at evaluating the evidence. So I don't like the way this is kind of twisted. I don't think it's appropriate that we're trying to dictate to a group of experts what they should and shouldn't be doing. I think this just ends up looking like a political exercise, in that we all disagree with their conclusion, but I think the right way to do it would have been to strongly recommend that they reconsider it. Hopefully they will. We've already put in process other measures to review this, and my understanding is that we've also looked at reviewing the way the panel is formed and decisions made by the task force. That the minister has already said he's going to do that. Anyhow, I think we would have been a lot better off leaving the original amendment. I think this goes too far, and I think nowadays everybody's an expert in everything. Everybody's an expert on the evidence. However, I think we all have to realize that we as parliamentarians are not experts in everything in life. And I think this has just gone too far. Thanks.
Thank you, Dr. Pawlowski. Are there any further submissions with respect to the sub-amendment? Seeing none, are we ready for the question on the sub-amendment? The sub-amendment is simply to delete the word direct in the amendment and substitute for it the word urge. All those in favor of the sub-amendment, please raise your hand. All those opposed? Okay. We only had one Liberal vote. Yeah. Ms. Goodridge, did you have a point of order? Oh, you want to speak on the amendment. Okay.
Monsieur le Président, il manquait des joueurs autour de la table.
Mr. Chair, we were missing people around the table when we voted.
Clear sense it doesn't appear that people are paying attention. I would ask the clerk to conduct a recorded division on the sub-amendment, please.
Okay, on the sub-amendment to change the word direct to urge, Dr. Hanley.
So am I on? Yes.
Thank you. Madame Kayabaga?
Oui.
Merci. Mr. Nakvi?
Sorry, I
On your on the sub-amendment?
we're voting on what? Sorry.
We're asking you to vote on. We're asking you to vote on your sub-amendment.
Thank you. I was engaged in a conversation. I was having a sidebar. I do not appreciate comments that are, we're just all trying to do our job.
Please.
Point of order, Chair. Point of order. I think that we're in the midst of a vote here, not a
Point
debate.
of order. If he's going to comment on that, then maybe he should pay attention to what's going on.
Please, Mr. Nakvi, your vote, please.
Yes.
Thank you, sir. Dr. Pulaski?
Or
Thank you, sir. Ms. Sidhu? Ms. Vecchio?
No. Sorry. I was just saying yes, that's my name. No.
Thank you very much, Ms. Vecchio. Dr. Ellis?
No.
Ms. Goodridge?
No.
Dr. Kitchen?
This is how it's done. No.
Monsieur Thériault?
Oui, je suis pour le terme exhorté.
Merci. Ms. Zerillo? Ms. Zerillo, yes or no on the amendment?
Nope.
Thank you. 1, 2, 3, 4, 5. 5 yeas, 5 nays. Sir?
There you go, Chair. The chair votes in favor of the sub-amendment. The sub-amendment is therefore carried. And we're on to the amendment as sub-amended. So this is Ms. Zerillo's amendment with the word urge instead of direct. Is there any debate on the amendment as sub-amended? If not, are we ready for the question? Could we have a recorded vote, please, on the amendment as sub-amended?
Yes, sir. On the...
Monsieur le Président, il semble y avoir
Mr. Chair, there seems to be some confusion across languages. In French, we agree on the word exhorter, but we don't seem to be agreeing on the term in English, exhorter, which is the right word in French for urge. So I'm having trouble understanding. What you're saying is that we will be replacing, what are we replacing? Yes, the word urge is the word for exhorter in French, and it's the same definition. Okay, but because we voted against that in English, didn't we? Urge is the English term.
Il y a des problèmes de je vais juste m'assurer que
I just want to make sure that I'm voting as I wish, appropriately. So, you want to change your vote? No, I don't want to change my vote. I just want to, as you're stating it, And as it's translated, for me, the term exhorter, and that's the most effective term, so we should use exhort rather than urge in English. But I understand there's no equivalent in English, so this can't work.
OK.
It means the same thing in English to say urge as it means to say exhorter or inciter in French.
Okay. In order, regardless of the reason, in order for Mr. Thériault to be able to change his vote, it requires unanimous consent of the committee. Does Mr. Thériault have the unanimous consent of the committee to change?
J'ai pas envie de modifier mon vote, mais
I don't wish to change my vote, Chair, but you're calling a vote regarding which I would like, before I must vote, to hear an explanation and clarification.
Je m'excuse, Monsieur Thériault, j'ai mal.
I'm sorry, Mr. Thériault, I had misunderstood you. From what I understand, is that the translation of the sub-amendment does not use the word exhorter, but uses another word. In the original version, for direct, it uses ordonner. No, that's not it. But continue. Perhaps I'll see clearly. You called a vote. And in the vote that you called, for that vote, you indicated the word exhorter, or urge in English. And what would a better word be? To direct, but that's not what we want. Direct is what we're changing. I'm not trying to find the right word. I'm simply saying that the word exhorter, or urge in English, is what I would like. Then you called a vote. I just want to make sure that I indicated that urge is what I would like. So I'm not starting my vote again. But now you're calling another vote, I understand. So I want to make sure that we've got the right terms in English and in French for the vote you're calling again now.
So
the translation of the word urge in English is exhorter in French. Yes, indeed.
With going ahead with a recorded division on the amendment as sub-amended, please.
Okay. Dr. Hanley.
I support.
Madame Kayabega.
Oui.
Monsieur le Président, est-ce que vous pourriez au moins redire?
Chair, could we at least hear again the amendment? Could we reread it before we vote on it?
Okay. L'amendement comme sous-amendement.
So the amendment as sub-amendment is as follows.
After the word guidelines, comma, to insert the words, and so were a majority of the witnesses, comma, and to add at the end of the motion after the word lives, period, the following, and that the Minister of Health urge the task force to go back to the drawing board and revisit the guidelines based on the latest science, period, and that the Public Health Agency of Canada table to this committee the parameters given to the task force to update breast cancer screening guidelines. Are we clear on what we are voting on? That is the amendment as sub-amended. Est-ce que ça fonctionne?
So is this working for you, sir? Wonderful.
If it's all the same, I'm going to restart. Dr. Hanley.
still support it.
Thank you, sir. Madame Kaibega.
Toujours oui.
Merci. Mr. Nakvi.
Yes.
Dr. Pawlowski.
Abstain.
Abstain. Ms. Sidhu.
Support.
Ms. Vecchio. Yes. Dr. Ellis.
Yes.
Ms. Goodridge.
Yes.
Dr. Kitchen.
Yes.
Mr. Thériault.
Oui.
Ms. Zerillo. 10 yeas.
The amendment as sub-amended is therefore adopted, and we're now to the main motion as amended and sub-amended. Is there any debate on that motion? Are we ready for the question? Do you think we can do this by show of hands? All those in favor of the motion as amended and sub-amended, please raise your hands. All those opposed? Any abstentions? The motion is therefore adopted. Dr. Ellis has a motion that I think will be uncontroversial. Dr. Ellis, go ahead, please.
Motion to adjourn, please, Chair.
Do we have consensus? The meeting is adjourned.